welcome to our video. My name is Bufan and I will be the host of today's conversation regarding evolution and depression. According to the American Psychiatric Association, depression is a very serious medical illness that affects the way you think, the way you feel, and how you act. So basically we know it's pretty bad. According to the estimates of the World Health Organization, about 350 million people around the globe are suffering from depressive symptoms. And, with the statistics, we couldn't help but wondering, is this adaptive? It doesn't seem to be the case at the first glance because, pathological depression is just so debilitating. How could it be adaptive? But if it's not adaptive at all, how could it be so prevalent among humans? I don't know about you guys, but these are the questions that keep me up at night. You have no idea. Fortunately, today we have three people who are actually experts in evolutionary psychology, and they will shine some light on the mysteries behind the relationship between evolution and depression. So we have Jared and Emily, who will be sharing their insights on whether or not depression is actually adaptive. And we also have Sarah, who will be looking at depression from a neurological perspective. And Jared, you're up.
So before we jump into how depression may actually function as an adaptation, let's first consider what an adaptation is and what is necessary for a trait to be viewed within an evolutionary context. So typically, adaptations are defined as traits that increase an organism's fitness and that have resulted from the process of natural selection. Not all traits are adaptations, though. In order for a trait to be viewed within an evolutionary context, it should be widespread within the considered population and show some degree of specialization. In light of these requirements, it is actually possible to consider depression in an evolutionary context. Depression has been estimated to affect approximately 6.5% of the population at any given time, with some studies suggesting that as many as 1 in 4 women experience depression at some point during their life. Additionally, because depression often emerges following aversive events such as the loss of a loved one, it has been suggested that specific contexts can actually increase the likelihood of developing depression, and thus it is actually a specialized mood state. Taken together, the prevalence of depression, the specific context in which it emerges, and its persistence in the human population despite its seemingly deleterious effects, suggests that depression may actually be an evolved mood state. Addressing is the infection hypothesis, and this hypothesis states that depression is an adaptive mood state because it helps to reduce the risk of infection. At the theoretical level, it has been postulated that the reduction in motor activity that often accompanies depression helps an individual conserve energy and resources so that they can better fight off infections. Additionally, the social withdrawal that is characteristic of depression has been thought to reduce the likelihood that the depressed individual will transmit their infection to conspecifics, as well as preventing the depressed individual from being exposed to new pathogens while already sick and having a compromised immune system. Additionally, clinical studies have reported an increased rate of depressive symptoms following infection, and Musselman et al. In 2001 reported that administration of pro-inflammatory cytokines, which are signaling molecules released during the immune response, resulted in the emergence of depression in a significant numbers of patients treated with these cytokines.
The infection hypothesis suggests that depressive symptoms could help facilitate the conservation of energy and reduce the risk of transmitting the infection from individual in distress to other members of the community.
The third hypothesis I'd like to explore is the social risk hypothesis. So this hypothesis is based on the finding that depressive episodes often follow events of considerable loss, being that of the loss of a loved one, a job, status, etc. And it states that individuals with stable social relationships are able to take more social risks compared to individuals with poor social relationships. Thus, when someone experiences a significant loss, their behavior would be expected to reflect the destabilization of their social circle. This is where depression comes in. The reduced mood and increased passiveness found in depressed individuals is thought to reduce the likelihood that the depressed individual will challenge others, thus reducing the likelihood that their social circle will be further destabilized. This hypothesis is actually supported by numerous studies that show a correlation between depression and perceived social value, perceived social threats, and the social problems in general.
Social risk hypothesis states that social passiveness could help prevent further destabilization of the social circle of the individual in distress.
Although some scientists have theorized that depression is an adaptation, others disagree with this hypothesis and instead believe that there are some components of depression that may be adaptive. But depression as a whole is not. Now we're going to hear from Emily, our resident expert, who disagrees with Jared's perspective. So Emily, you heard Jared. He believes that depression is adaptive. So what's your take on this? Do you agree with him?
While aspects of depression may be adaptive, I would hesitate to call pathological clinical depression an adaptation. Psychological disorders, as defined by the DSM-5, are distressing and impairing. Those who suffer from depression often find it debilitating. To call depression an adaptation, then, may minimize these experiences and may romanticize the disorder. It also raises questions from an evolutionary perspective. Why would prolonged, debilitating impairment be beneficial to fitness? What Jared's sources seem to suggest is that pieces of depression are adaptive rather than clinical pathological depression as a whole. I find it more likely that symptoms of depression evolved for our fitness, and that malfunctions in the systems that regulate these symptoms are accountable for clinical depression. Depression as a complete package appears largely harmful, but what about the components that it's made up of? Keller and Ness studied low mood in relation to various precipitants. They found that different causes of low mood prompted different behavioral and emotional responses. This suggests that depressive symptoms were designed to cope with different life stressors.
So where does this leave theories that Jared just talked about?
In terms of reducing infection risk, symptoms like fatigue and isolation would do the job, rather than depression as a whole. Fatigue, according to Keller and Ness, promotes energy conservation, and as Jared points out, avoiding contact with others would reduce the risk of contagion. It's the same story for the social risk hypothesis. Sure, passivity may prevent you from annoying your friends, but passivity is not depression. Research shows that full-blown depression can actually harm relationships. Depression is correlated with interpersonal deficits, and stigma is a relevant concern.
So does other research data support the statement that depressive symptoms could be adaptive?
Other studies do seem to support this adaptive symptom theory. Oquendo and Associates, for example, assessed the consistency of depressive symptoms in a population of depressed individuals who had multiple depressive episodes. Members of their sample expressed different symptoms during different episodes, and the manifestations of their depression were largely inconsistent. I interpret this research as proving the potential adaptive qualities of various symptoms of depression. Perhaps, different episodes were brought about by different stressors, and these stressors require different low mood responses. Those with major depressive disorder may have a predisposition to malfunctioning mood responses, heightening these otherwise adaptive symptoms to pathological levels. Other data bolsters this hypothesis as well. Carell and Associates studied the reoccurrence of depressive subtypes in patients with major depressive disorder. They followed their sample for years and studied the characteristics of their depressive episodes. For each subtype of depression they studied, symptom stability was most prevalent in consecutive episodes. I would postulate that these findings relate to the precipitants of each episode. It seems more likely that sequential episodes would share a precipitant and therefore call for the same low mood response. Of course, this literature is far from conclusive or exhaustive, and if low mood symptoms are adaptive and clinical depression is not, we need to decipher why clinical depression exists and how it stems from components that are evolutionary beneficial. For example, I don't think that clinical depression is as simple as being a response to an observable, recognizable stimulus. Low mood symptoms, however, at least according to this research, may come closer to being so.
Emily made a crucial distinction between sporadic depressive symptoms and pathological depression. Ample data suggests that the former could be adaptive, but the latter has been shown to be much more debilitating than adaptive. In other words, feeling sad after going through a negative event could potentially protect an individual from further social harm. However, if those feelings persist and interfere with a person's ability to live a normal life, they could be interpreted as a kind of debilitation or illness that does much more harm than good. So, what can the brain tell us?
It is pretty obvious that when experiencing depression, the person is very likely to show signs of, distress that could be observed directly from the outside. Emily and Jared talked about phenotypic expressions of depression. Believe it or not, depression is also correlated with changes of the brain that could not be observed from the outside. Here's Sarah talking about depression from a neurological perspective, specifically the roles of dendritic spines in depression. But first question, what are dendritic spines?
Dendritic spines, what are they? A lot of people are wondering what their role is in depression. So spines are small perfusions found on the dendrites of neurons. And although their functional significance still remains somewhat elusive, recent evidence suggests that spines act as sites of excitatory synaptic transmission in the central nervous system. They seem to be the primary recipients of excitatory inputs and provide compartments that locally control the signaling mechanisms at different individual synapses. So essentially, they help transmit electrical signals to the neuron cell body, and that assists in communication between neurons and ultimately affects how your brain and body reacts to stimuli.
If we look at the picture to the right, we can see the presence of spines on the dendrites of a pyramidal neuron located in the hippocampus. Spines are the small perfusions or knobs located on the dendrites of a pyramidal neuron, which is a common type of neuron found in the hippocampus. The hippocampus is the area of the brain in charge of memory consolidation, and spines provide an anatomical structure for memory storage. They may also serve to increase the number of contacts between neurons and increase synaptic transmission of information from neuron to neuron. This could allow our brain to react to stimuli more quickly. On the flip side, with less spines, we experience a reduced reaction to stimuli, potentially producing behavioral outcomes of melancholia, lack of initiative, reduced energy, and sadness typical of depressive mood.
So the fascinating thing about spines is that they're plastic. They constantly change over time. Modifications to spines may alter functional efficacy of synaptic transmission and the structure of neuronal connections, altering the way in which neurons communicate. In some situations, slowing down the process or sometimes stopping neuronal communication altogether. And these changes can be bad, but they can also be good, and they happen naturally throughout your life. So changes in spine density and morphology occur during development, learning, aging, and as a result of various types of mental disorders such as depression.
So to recap, research has implicated dendritic spines in the transmission of electrical impulses to the cell body, and believe that they are storage sites for synaptic transmission that ultimately helps neurons communicate with the central nervous system.
So recent studies have shown apoptosis and atrophy of neurons in the dentate gyrus and CA1 and CA2 regions of the hippocampus in patients with depression. Essentially, individuals who suffer from depression have been found to have a smaller hippocampus, and we are constantly wondering, why does this happen? And some people believe that such a reduction in hippocampal volume has to do with the severe loss of hippocampal spine synapses. Studies have found evidence to suggest that depressive behavior is associated with hippocampal spine loss. So researchers have recently reported that male rats that develop helplessness behavior is associated with a severe loss of hippocampal spine synapses, which is, funny enough, reversed by antidepressant drug treatment. So in psychology, learned helplessness is a mental state in which an organism is forced to bear an aversive stimuli, such as an electric foot shock. And as a result, this individual becomes unstable or unwilling to avoid subsequent encounters with such stimuli, even if these unpleasant situations are inescapable.
To give us a better idea of how learned helplessness is induced in animal subjects, we are now going to quickly investigate how the electric foot shock is used to induce depressive behaviors. Seligman was the first researcher to use this method in the 1960s. In one of their experiments, they placed a dog in a special cage that had a low barrier dividing the cage into two compartments. The floor of each half of the box had an electrical grid that could deliver a painful shock to the dog. The researcher could flip a switch to direct the electrical current to either compartment A or compartment B. So far, Seligman's research simply replicated what other researchers had already found. Naive dogs will quickly escape the unpleasant event, and if possible, to avoid that event entirely. But then, Seligman tried something new. He strapped some of the dogs into a hammock and gave them an inescapable shock at random intervals. The next day, when these dogs were tested in the shuttle box, the dogs would jump around frantically as soon as they felt the shock, but after a few seconds, they would stop moving, lie down, and begin to whine. Rather than jump across the barrier, the dogs passively accepted the painful shock. Seligman concluded that the dogs in the hammock had learned that they could not escape or avoid the shocks. That is, they learned that they were helpless and that the shocks were uncontrollable. This conditioning was so powerful that when the dogs were placed in a situation in which they could escape the shock, they didn't even try, because they had formed the expectation that they could not control the environment.
Such behavior shows an inability or unwillingness to act due to negative presumptions about the future, a low self-esteem, chronic failure, sadness, and these behaviors are closely linked with behavioral markers of depression. Researchers have used the electric foot paradigm to induce depressive symptoms in rats and then monitor changes in morphology and density of spines in the hippocampus. So while the underlying mechanisms of dendritic spine plasticity is still unknown, researchers have started focusing less on the use of reuptake inhibitors and serotonin antagonists to treat depression, and now we're looking more at spine density and spine morphology as a potential cure.
So that concludes our video. We learned about depression under an evolutionary perspective and how it may or may not be adaptive. We also learned about the neurological underpinnings of depression. So what do you guys think? Leave your comments down below because we would love to see your comments, obviously. If you like our video, please give us a thumbs up and hit subscribe. Thank you, Jared. And a big thank you to Jared, Emily, and Sarah. I can't see them, but you guys can. And also thank you so much for watching the video. We'll be back next week with more cool stuff, so stay tuned. Bye.